All right, thank you so much. You can move to the next slide, please. Uh, my name is Andrew Shermeyer. I'm a PhD candidate at the University of Minnesota, and I'm going to discuss the effect of eliminating cost sharing on behavioral health service utilization and affordability in Colorado. Next slide, please. All this research, I owe a lot to a lot of people. So thanks to Civic, these individuals, and some funding. Next, please. Great. So to set the context, one of the challenges we face is providing comprehensive but also affordable behavioral health care. There's a lot of barriers when it comes to this, including stigma surrounding behavioral health, availability of services, and more financial ones like insurance coverage and the high cost of care. So there have been numerous strategies states have undertaken to address this. Of late, there's been one has been to eliminate cost sharing altogether. We've seen this in New Mexico, and another example is in Colorado, actually, in the Colorado option. So if anybody is unfamiliar with the Colorado option, in 2023, Colorado passed House Bill 21, implemented, I should say, House Bill 21, 1232, established this public option, quasi-public option, if you will, and required all insurers in the marketplace to offer additional standardized plans with shared benefit designs. Part of this benefit design was a $0 behavioral health office visits. So essentially, economic reasoning, we would think that, oh, no cost sharing, this could encourage and incentivize use. And that was exactly what the policy intended. However, it remains unclear if consumers actually responded to the $0 copays. And this leads to the next slide, please, of the research objectives. First, to determine if individuals enrolled in one of these Colorado option plans utilize more behavioral health services than those enrolled in a non-option plan. And also, another objective is to actually quantify the difference of out-of-pocket cost savings for these two groups of people. Next slide, please. To accomplish this, I conducted a retrospective cohort study using the Colorado APCD, using years 2021 to 23. So 2021 and 2022, purely to establish baseline health status. I used all 3 years to find people who were continuously enrolled or had 11 or more months of coverage each of those years. This removed people from the special enrollment period, which has been in the literature shown to have some potential adverse selections. That was important. And then the outcomes I'll discuss later are from 2023 only. But so the sample included about 50,000 individuals in total between 18 and 64 who were continuously enrolled in a marketplace plan or coverage, I should say, between these years. The treatment group was about 7,200 individuals enrolled in the Colorado option plan. I considered the comparison group the remaining 43,000 individuals enrolled in a non-option plan. So if you're getting alarms in your head, it's totally valid. There is treatment selection bias by defining treatment this way. I'm going to discuss how I mitigated that in the methods slides. So next slide, please. So my outcomes of interest, I cared about the probability of using any behavioral health services. This is a binary yes or no outcome. I also cared about the amount of behavioral health services used for individuals that used any to begin with. This is kind of like intensity of usage is another way of thinking of this. And then lastly, of course, to quantify the out-of-pocket savings, we want to know the average cost of behavioral health visits. So next slide, please. That'll go into the methods. So I used a two-part model for this. It's also called a hurdle model in the literature. So the first part of the model is an equation called a decision model. And this identifies the probability of using any behavioral health services based on someone's treatment status or the plan they were enrolled in 2023. From this, we go into our outcome models, the second part. And so the second part is concerned with only is conditional on people passing the hurdle or having used services to begin with. And I ran separate equations to model usage and cost to get those intensity of utilization and the cost outcomes. But I want to specify, because of the treatment selection bias, I had to use inverse probability of treatment weighting, IPTW, to mitigate this effect. I'll save you all from the methods discussion about how that's actually done. I'd love to talk about it later. It's really cool, but moving forward, let's talk about some results in the remaining time we have. So interestingly enough, in terms of the decision model, that binary outcome, I didn't find a difference between the probability of using any behavioral health services based on whether an individual was enrolled in a Colorado option plan or a non-option plan. Below, I'm showing the average marginal effect of treatment compared to people enrolled in that plan or in one of those plans versus a normal non-option plan. And the 95% confidence interval is also listed there. So you're seeing it cross zero. So it's statistically insignificant. Next slide, please. The outcome model for utilization, I actually didn't see any association between the plan choice of an individual and the amount of services utilized. So there was no difference I found between enrolling in an option and a non-option plan between the counts you used. Again, we have average marginal effects. The confidence interval crosses zero, not significant. Next one, please. This is the kind of interesting result. So as expected, we are seeing some savings from enrolling in a Colorado option plan. And it makes sense. Eliminating cost sharing should, reduce out-of-pocket spending. But now we've quantified it, and it's about $23 less. So what does this mean? And next slide, please. So I think this just raises some questions, right? And I have why didn't utilization increase? So I have a few reasons. One is that costs couldn't be the only barrier. In the 2023 Colorado Health Access Survey, it was the first time that the survey said that cost wasn't the main barrier. And also the benefit design doesn't really touch upon stigma, availability, or accessibility of services. The second reason, I think we need to consider the context of behavioral health services. A lot of the time they can be correlated with crises, and you don't really plan on a crisis by definition. So therefore, I think people might be less price sensitive to these services than other services. The third reason is competing mechanisms. There could be prior authorizations, different networks, even provider reluctance to see individuals based on negotiated reimbursement rates. We've seen this in Medicaid. The literature points to that. I've not investigated that yet. I'll talk about next steps. But the other reason would be a lack of awareness of health benefits. The 2024 Consumer Engagement and Healthcare Survey said that about 40% of individuals don't know their behavioral health benefits in insurance plans. So this could just be something we've seen, it's a new product when people selected one of these plans. Next slide, please. I'll just wrap it up quickly. Essentially, eliminating cost sharing reduced out-of-pocket costs like we expected. by an average of $23 a visit, but we didn't see that increased utilization of behavioral health services. And I think this suggests that we really should prioritize, that we need to think about the non-price barriers to behavioral health care, such as the availability and the accessibility of these services. And I plan to do more work on this to investigate how provider networks and reimbursement rates changed. And I'd also like to see if there's variations based on region or if there's heterogeneous effects in case, the newly enrolled in 2023 had a different effect than those continuously enrolled. So yeah, that wraps it up. So thanks so much for listening. Feel free to type in questions or email me with any, and I'm happy to discuss this.
Awesome. Thank you so much, Andrew. That was great. Looks like we've got just a couple of very quick questions here. Oh my goodness, there's a whole bunch and we're about to go over. So everybody, I would ask, I am so sorry. If you can reach out to Andrew, his email is right here, and I'll put it in the chat as well, and ask him your questions. There, I just saw like four come in, so I don't wanna hold everybody over. I'm sure people are anxious to get to lunch or on to their next meetings or whatever, and I want to be able to get us out of here. So my sincerest apologies to that for that, Andrew, and everybody whose questions we weren't able to get to. But I am copying the chat as well, and I will follow up with that as well from my end. So my apologies. Thank you so much, Andrew. That was really, really interesting. Clearly, everybody else thinks so too. All right. So thank you all so much for coming to our presentation today. You will get a follow-up email that will have a recording as well as further information in the slide deck. So feel free to touch back with our presenters as other questions or thoughts come up. Feel free to reach out to us if you sparked some ideas for how you may be able to partner with Civic, use CO APCD for any of the projects you're working on. Please connect with us. We are on Facebook, LinkedIn, and not Twitter. Got to get that out of there. We are on Instagram, though. And sign up for our newsletter. So with that, I will let you all get on to your afternoons. Thank you so much for your time today, and have a great rest of your Thursday. Thank you.